Welcome everyone to our 10th VT Reach session. VT Reach stands for Virtual Teleconference, Reach, Explore, and Aspire to Careers in Healthcare. All of our sessions are recorded and put onto our YouTube channel at VT Reach. And tonight we're getting to dive into pharmacy.
So for this session, it's going to be spotlighting pharmacy, and we are joined by a couple actually, Jenessa and Jeff Gonzalez, and they work at the UVM Med Center as well in the pharmacy. And so we'll be hearing from them about their journey to where they got to where they are, and a day in their life and their responsibilities. So without further ado, I will hand it off to them.
All right, thanks for that introduction. So I'm Jeff. I am. Can they see me on the thing? Sorry. So I'm Jeff. I'm one of the pharmacists at UVM Medical Center in Burlington. I am a clinical staff pharmacist there, and I've been there. All right, there we go. For what is it, 8-9 years at this point in time. So my inspiration into medicine, my family has always kind of been in the medical field. My mom was a nurse. My dad's been in hospital administration for a very long time. And so I always knew I wanted to do something medical, but, I never really wanted to be super hands-on and touch people, and actually get up close in there. So I thought pharmacy would be a really great way to be involved with medicine without, having to do kind of a lot of the surgical kind of stuff and anything like that might come with being a physician. Originally I thought I might be interested in doing some sort of pharmaceutical research and really doing a lot of bench work and trying to research new drugs and come up with solutions in terms of coming up with new medicines for diseases and whatnot. But, after a couple chemistry classes at college, I quickly decided that, this really isn't for me. And I would like to do something maybe a little bit more practical other than sitting in the lab coming up with compounds. So where am I from? Originally from Florida, and so I often get that question in terms of why did you move from Florida all the way up to Vermont? So I went to the University of Florida. And, when we talk about pharmacy schools and programs and kind of the overall structure of it, it is kind of interesting to think about, looking at a specific program that you might be interested in, because there are a couple different breakups of how they work. So some programs, like where I went to, it's a 2+4. So what that means is you have to do 2 years of pre-pharmacy work, which is a lot of science classes, Chem 1, Chem 2, Orgo, anatomy, physiology, biochem, stats, and you get all that stuff done. And they give you an associate's degree after that two years, but then you have to apply again to pharmacy school, and so that's a whole application process. And I had to take a test called the Pharmacy College Admissions Test, or the PCAT. But actually a lot of pharmacy schools these days are kind of phasing that out, and making it a little bit more of an optional test. But then, with your application, you have to go interview. And once you get admitted, then you're admitted to pharmacy school, and that's a 4-year process. And
it's a doctorate program.
Yeah, and so you will end up with a PharmD, so that's a doctor of pharmacy degree. So, when you graduate, you are called Dr. Jeffrey Gonzalez, and then you can become a pharmacist, obviously. And then there's a couple different options after pharmacy school. So to kind of give you a quick overview of how that works, after pharmacy school, you could go straight into the community and work as what most people think about when they're a pharmacist, is to be a pharmacist at CVS or Walgreens. But if you're interested in more like a hospital or some sort of specialty, you can do what's called a pharmacy residency. So you can see that a postgraduate year 1 or PGY1 pharmacy practice residency is kind of a generalized residency that gives you a little bit extra training while learning about stuff, and particularly to a hospital setting. And so, you are a licensed pharmacist at that point, so you can officially do everything that a pharmacist would do in a hospital, but you're getting a little bit more education and training throughout that year in the hospital. So you'll do rotations very similar to like a med student might do, or a pharmacy student might do when they're in school during their rotations. But you might circle through internal medicine, the SICU, surgical ICU, the MICU, oncology, all the different facets of medicine in terms of getting experience and practice with those certain areas. All right, so, I kind of talked about, a lot of people when they think about a pharmacist, you just think about the pharmacist at Walgreens and CVS who is filling your prescriptions and checking the prescriptions and checking interactions and making sure that stuff is, successfully goes through your insurance. And if you have questions, and helping people in the store answer any questions they might have about their medications. But a lot of people don't necessarily think about that there are in fact pharmacists that work in the hospital too. So my title is a clinical staff pharmacist. And, we have at UVM probably about 50 to 60 pharmacists on staff. And so there are a lot of different, what we call satellites throughout the pharmacy. And so basically each pharmacist is responsible for 1 or 2 units. And what we do on those units is, when a doctor places an order for a new medication for somebody who's admitted to the hospital, say with pneumonia, we get that order and review it electronically on Epic or whatever computerized system that you may have. And we review that order, say, hey, is it the appropriate drug for this indication? This patient has pneumonia. Do they have any allergies? What's their renal function like in terms of it? Can their kidneys handle it? And really assess the dose and the timing of the med. And then once we're comfortable that, yeah, this order looks good, we'll approve that order. And then it goes through the logistical process of actually getting that medication to the patient on the floor. And some medications are usually stored on the unit where the patient is. So it's as simple as a nurse going to this machine that we have called a Pixis, which is essentially a fancy dispensing cabinet that has all these locked meds into it. Or it gets something that we have to make in the IV room and compound it specifically for that patient. And then we make sure that that med gets sent to the floor, and then the nurse would administer it to the patient. Another thing that a lot of the pharmacists do is we have rounding responsibilities. So what does that mean? Well, so a lot of my job, I work in the surgical ICU a lot, and I round with the pediatric ICU team. And so, when I first go up to work and I look at the patients there, I actually have to, I'll review the patients and take a look at them. And then I'll meet up with the pediatric attending and the resident, and we'll actually go from room to room. And if I have any interventions for any of the medications they have, or if especially with a pediatric patient, if their parents have questions about any of their meds that they're receiving, we are right there and available to make suggestions and recommendations in real time, which is really helpful. And we can also help teach some of the medical residents a lot of specifics about, medications that they might not necessarily receive throughout their medical school curriculum. And the last thing that we do is review all the other patients. So if we're not rounding directly with the team, but we're responsible for some other patients and looking at their orders and their labs on a daily basis, we have certain criteria that will sort of look at a patient as a whole, and reach out to whoever's covering that patient in terms of the provider and make suggestions on dose changes. If they're running a new medication and we need to have something switched because there's an interaction. There's some medications that require specialized monitoring in terms of whether we have to check labs every day and make adjustments based on that. And that basically kind of sums it up as a whole.
And to just piggyback off of that too, I think it just kind of lays it out a little more clearly. So we're responsible when Jeff's talking about he's assigned to the ICUs for the day. That means that he's in charge of every single order that goes through, that is put into the computer for every single patient. And usually per assignment, I would say that's about, on a day shift, maybe 60 to 70 patients. So 60 to 70 patients, everything medication wise that the doctors want to do, the pharmacist does review. Whether they start or stop something, we review it every single time. And then the rounding responsibilities are kind of in addition to that. And it's more of a focused group of patients. So that's team-based. And when he says he's rounding with the pediatric ICU, on average, anywhere between maybe 5 and 10 patients he's seeing more in depth with the team.
And that's a great segue into the next thing. So your schedule depends on the position. And so there are a lot of pharmacists at the hospital, and we all kind of have a little bit different roles depending on where we're working. So, a lot of the clinical staff pharmacists will have a particular unit, so surgery, medicine, pediatrics, the medical ICU, the surgical ICU. All of these places have pharmacists that are responsible for covering those patients and making sure that the orders are verified, that everything is correct, that nothing needs to be adjusted, answering questions, that sort of thing. But our schedules can be a little bit flexible. So for us, we work 40 hours a week, but we have 8-hour days. And typically that's, if you're working a day shift, 8 to 4:30, but we do also work some evenings, like 3 to 11. And then occasionally 1 or 2 nights, maybe every couple months.
And I would say that's probably pretty typical for any hospital pharmacist, unless you have a specialized position, just because hospitals are typically open, 24/7. And we're in the unique position in Vermont where the inpatient pharmacy at UVM Medical Center is technically the only pharmacy that's open 24 hours a day. So somebody needs to be working to field any questions, not only from our own institution, but from the whole state.
Yeah, and so the third point on this slide where it says the pharmacist clinicians or ambulatory care pharmacists work usually Monday to Friday, 8 to 4:30. So, Jenessa and I both completed a PGY1 pharmacy practice residency, which really gives you like a well-rounded experience in terms of gaining a little bit extra training for how to be a successful hospital pharmacist. There are PGY2 pharmacy residencies, so postgraduate year 2 residencies. And again, that would be, you have your pharmacy school, your PGY1 residency, and then a PGY2 residency you could also do where you could choose to specialize in a specific area. So you could choose to specialize in critical care, you could specialize in emergency medicine. We actually have several emergency medicine pharmacists that work strictly in the emergency room at UVM. You could specialize in pediatrics, oncology, and those
infectious disease. The list is very long.
Anything I could.
And it could be outpatient as well. So you could specialize in ambulatory care. There are some community residencies.
And there are even some community practice residencies where
drug information. There's a wide range.
Yeah, basically, if you can think of a specialty in medicine that revolves, again, the pharmacy is involved at all, there probably is a second-year residency that you could choose to specialize in. Now, the pros of that is that you can, really become a specialist in that area, and you can, work Monday through Friday and love that spot where you are. But then you tend to be like, okay, once you do a critical care pharmacist, PGY2 residency, then you're kind of like, okay, I'm a critical care pharmacist. And it's a little bit hard to go back and be a little bit more of a generalist like we are. So we are probably a little more flexible in our options in terms of, if we ever wanted to move from Vermont, it would be probably a little bit easier for us to find a job as opposed to somebody that might have a PGY2 residency in psychiatry. And then they're looking for a particular, I'm going to be the psych pharmacist for, a particular hospital.
And the longer you work in your specialty, obviously the harder it is to pivot to a different specialty. But, we have multiple pharmacist clinicians that work with us in pretty much all the areas Jeff just mentioned. And us as clinical staff, we work together with them every day to, talk through complex cases, work on, education, projects, things like that, on different committees and things like that. So we work very closely.
So, I'll add the typical day in the ICU. I kind of talked about this a little bit already, but, usually arrive at 8, check in with the overnight pharmacist and see if there was anything that needs to be followed up by the day team. If somebody doesn't have a really good med list on profile when they're admitted to the profile, maybe I'll have to call the pharmacy that they fill their prescriptions at. I would call their outpatient pharmacy and double check and see what they get. And the picture that's on the slide right here is actually the workstation that I work out most of the time. So that's right in the surgical ICU at UVM. And it's a really great spot because after rounds, I sit there, and then usually right to my left, the medical residents and the surgical residents are sitting right there at the computer stations. They can just ask questions. I'm right there. The nurses come up to me and say, hey, I have a question about this med, or is this correct? And this is strange. So it's really nice to be accessible and available for both the doctors and the nurses to help answer any questions. And then the little point in the bottom, the varied scheduling allows for great flexibility to enjoy skiing. So for us, we actually really like, the option to have evening shifts. They're really great in terms of helping coordinate our schedules, so that if we wanted to have a bunch of evenings, we could go skiing in the morning and then work from 3 to 11.
Or if you have a doctor's appointment,
Yeah.
one morning, you don't have to take a full day off to go. It's nice. We like it. It's not for everybody, but I think we consider it a perk to our job. Oh, me already. Well, hi everyone. I'm Jenessa. Actually, Jeff didn't mention this, but we can actually go to the next slide because this is part of my story. But we actually met here during our PGY1 residency, but I'll start from the beginning. So I went to University of Rhode Island for pharmacy school. I'm originally from Massachusetts. My program was a little bit different than Jeff's. It was also a PharmD program. Pretty much that's all that exists now. But my program was a 0-6 program. So what that means is that when I got accepted to this program as a senior in high school, I was in unless I failed out. So I did not have to reapply after 2 years, but I also did not get an associate's degree after 2. So I could have quit, 5.5 years into my schooling and left with nothing. Obviously that didn't happen. But the perks to that is there isn't that reapplication process. Once you're in, you're in. And it really is, either a 2-4 or a 0-6 program is the fastest way to get your degree.
Some people take longer.
Some people take longer, and that's totally fine. There are mostly the schools like Jeff's where there is that 2-4 option. They do allow for someone who maybe has a bachelor's or another degree or is changing careers to apply and get into that program at that 4-year mark. So you just do the 4 years and get your PharmD because you've already had a previous degree. So there's different pathways to the same end. And mine was just a little bit different than Jeff's. I also included that I did have a minor in a couple of different areas, Spanish and biology for me. And I just included that for those folks out there that are curious if, the PharmD program is so rigorous, you can't do anything else. It is a difficult program, but absolutely you have, the flexibility to have a life, maybe pursue other interests. I was involved in multiple things during college as well. So it's definitely possible to have that balance. So like Jeff, I graduated in 2013 and then moved to Vermont to do my PGY1 residency at what was Fletcher Allen and is now UVM.
Which I will say, actually, applying to residency is a whole other application process that we didn't actually talk about.
Yeah, we didn't really talk about that, but we don't need to get into
okay, it is a whole other application process with interviewing and, and there's a whole match process similar to how the medical students get matched into their residencies.
Yeah, it's basically the same thing.
Yeah.
The difference being that this is not required for pharmacists. So, I could have graduated with my PharmD and applied to a job at a hospital and worked. That is totally fine. As the market gets more competitive, that's a little bit harder to do depending on where you live, just because we do have a wide variety and a lot of different PGY1s available now. So that's kind of becoming more of a standard.
Especially in the larger cities.
But, it's not required. So I moved up here and did that from 2013 to 2014 and stayed on at UVM, and I've been there ever since in the clinical staff role that we were describing earlier. Both of us actually, probably a year or 2 after we finished residency, decided to pursue a board certification. It's kind of an additional test basically as a pharmacotherapy specialist. I only mention this because there's other avenues. So I could become a board certified pharmacy specialist in infectious disease or pediatrics or wherever you end up practicing. It's kind of another way to stay abreast of a lot of the new information in that area. And it's another, certification that makes you more marketable essentially. But we do it basically for the continuing education because it forces you to keep up to date because this is a field, as with any, really thing in the medical field, it's constantly changing. There's, new data every day and new drugs that come out, drugs that are get taken off the market. So it's a lot to keep up with, and that helps us do that. So I won't, beat a dead horse here. I know Jeff kind of gave a general overview of what we do on a day-to-day basis. So just to kind of piggyback off of what Jeff was saying, for me, we basically have the same job. I just work in slightly different areas than him. For me, I mostly work in internal medicine and inpatient and outpatient oncology. So for my portion of the talk, I figured I would focus more on the outpatient infusion pharmacist role, because it is a little bit different than what we were just talking about. So in general, same idea. We do all the order verification and product checking for everything in the hospital. So the process we described, where the physician writes the order, we review the order, how that relates to the patient, approve it or not. And if it is approved, then there's the whole logistic aspect of it, where it's prepared and leaves the pharmacy. And I just wanted to mention that before it leaves the pharmacy or is able to be taken out of that medication locked cabinet that Jeff was talking about, it is checked usually again by another pharmacist. So especially if it's coming from the pharmacy, we'll get into that when we get to talk to when we talk about the case. It'll be a little bit more clear. So there's multiple points in care where a pharmacist has their hands in. There's a lot of communication with our job. So we're constantly talking to nurses, physicians, but I will say that as a hospital pharmacist, we don't speak to patients as much as you would see it in the community setting. We like to say our customers are more of the nurses, but we do have some hats that we wear that involve, talking to patients and answering their questions. And that will just depend on your role in whatever hospital you're in. My role in the infusion pharmacy, I do have more patient face-to-face interaction probably than the typical day in the inpatient pharmacy, but it's still, I would say, nowhere near what you would have in the community setting. Generally speaking, whenever we're working in an area that's not where you saw that picture of in the unit, so if we're working in the actual central pharmacy, so we have this big room essentially in the middle of the hospital that houses all of the drugs, basically most of the technicians, and kind of all of our fancy technology. So when we're working in that area, we have a lot more oversight of technicians and kind of managing their workflow. So that is part of our job as well. And then the other piece, we do work at a teaching hospital, and if that's the case, regardless of where you are, there's going to be a requirement for you as a pharmacist to teach. So we precept pharmacy students, pharmacy residents, so those that the PGY1s we were talking about or PGY2s. And also there's a lot of education that happens with medical students, sometimes nursing students, just kind of depends on your role. So as far as the oncology pharmacy goes, a lot of this is kind of just general stuff as well. So I'm working specifically with the oncology team, assisting with chemotherapy order writing. We're always ensuring safety. That's kind of the name of our job.
Right.
And a little bit, something that I'm thinking about a little bit more as an infusion pharmacist is minimizing waste, because I'm dealing with medications that are extremely expensive. To give you an idea, I was working there today and there was a patient that came in who hadn't yet gotten authorized for an infusion that she was getting. We noticed this and realized that she couldn't get treated because if we did that and without it being approved through her insurance, it would have cost her $42,000 for one infusion. And that is actually pretty average. The medications are extremely expensive, so we want to minimize any waste going on. And then either role, we do assist in developing more institutional wide policies. So, working with interdepartmental groups and coming up with kind of like rules that need to be followed essentially. But it's nice to have pharmacy's input,
Right.
especially if it involves medications.
For example, the most recent one is that pharmacy is heavily involved with like our COVID-19 patient treatment algorithm in terms of, early on in the pandemic using, okay, should we use hydroxychloroquine and which patients will qualify for it or should we not? And then as we gave more data, then we took it off the protocol. And so that is a interdisciplinary group of physicians and pharmacy, nursing, and to come up with these, policies that get implemented throughout the hospital. So that's just an example.
And I'm glad you mentioned that too, because I think that it's really important to stress, and I actually didn't even realize this until I was deep into pharmacy school. But such a big part of our job is knowing how to interpret primary literature. So how to look at clinical studies that were done, interpret them, decide if they were done well or not, understand how they analyzed everything, and apply it to our practice. So that's our job. So in the case of COVID-19, that's a great example because it's happening right now. There are pharmacists that review all these new studies that come out with all these medications and basically advise, we should or should not use this. This is the situation we should use it in or should not. And that's kind of on a bigger scale, but that's something that we do every single day.
Right. And there's so much logistics that come along with that too, in terms of, there's a lot of technology involved. I'm going off track a little bit, but there's a lot of technology involved in the pharmacy of when we had the Pfizer vaccine, we need to get a special freezer that has this, how does it get shipped to us? And how do we actually, get these things to the patients and to our staff? And so all that stuff, pharmacy gets involved with a lot of the nitty gritty that you wouldn't normally assume when you're in school that you're going to be helping, you're not going to be responsible for.
Yeah. Everything from the higher up clinical picture all the way down to how do you logistically make this work?
Yeah.
We have to think of. And I think that's a really fun point to our job. Oh, wow, pictures. Okay. So kind of basically, I won't repeat this. So 40 hours a week, the outpatient clinic hours specifically are listed here. So for us, even though I work in the outpatient clinic sometimes, or I would say maybe, 4 to 5, 10, that I'm still considered an inpatient pharmacist because the rest of my time I'm spending inpatient. So I'm never really working Monday through Friday, 8 to 4:30, but that's okay. Okay. Other things, so similar for me, those are the hours listed there. We have a pretty large operation, definitely nowhere close to see in Boston or anything. But we're serving, the pharmacy probably serves 60 to 70 patients a day in the oncology clinic. That means that there's probably 60 to 70 patients average receiving a chemotherapy product. And they could be receiving 1 or 6. It depends on their regimen. So as far as number of products that go through, it's far higher than that. Also because we not only serve our adult outpatient infusion center, which is at the main campus, but we also service the pediatric, we also service, and we basically make anything that's hazardous in this section of the pharmacy. And that's because we have these special laminar flow hoods or biological safety cabinets that allow us to make them safely. And we have the only 3 in the hospital. So this infusion role is, I should have mentioned this earlier, is kind of a annex or a separate area of the pharmacy, or what would you call it? Another pharmacy, essentially, but it's smaller.
It's kind of like a baby pharmacy that only does hazardous stuff.
Yes, that only.
It's right by the lab. Yeah.
So there, with that said, there needs to be specially trained pharmacists, but also specially trained technicians, because it's a whole different kind of skill set to be able to make hazardous products. And I personally, in that baby pharmacy, work with 3 pharmacists. So it's myself and 2 others, and then 4 total technicians that are kind of making this part of the pharmacy run every day when the clinic is open. There's my dog, Millie. I locked her out of the room because she would be loud, but she's very sweet. And I think that we have a very good work-life balance, and she's part of the fun parts when I get home.
All right, thank you both so much. Lily and I have some questions, and if anyone in the chat, feel free to drop your questions in, and Lily and I will ask them. I was wondering just what type of classes are you taking in your upper level pharmacy, like the doctorate program?
Oh, that's a good
That's a good question, and I'm glad you brought that up because I meant to elaborate a little bit more on that. So for the upper level section of schooling where you're kind of done with your prerequisites and your, chem, organic chem, microbiome, biochem, those are all kind of what you would take in that first 2 years. For me at Rhode Island, I think every school probably structures it slightly differently, but from years, so your first professional year, first, second, and third professional year, you are in lectures. And for us, they had what they called core topics. So each semester we had kind of like a theme. So for example, there would be a cardiology and renal core. And so every class that we took kind of stuck to that theme. So we took therapeutics, pathophys, and like biochem, all to do with that theme. And thank God, what else did we take? There was other things thrown in there, like palliative care, things like that. But he can get more into that. But what I wanted to say was that after those 3 years of lecture, everybody has 1 year of applied clinical learning or rotations. So your last year, you are going out and about and doing more kind of like what you would do as a med student years 3 and 4, and kind of being out there kind of practicing under licensed pharmacists.
Yeah, and UF, they have since switched to that module-based program where it's kind of like renal, an endocrine module, a cardiology module. But when I was there, it was just basically there's, your first couple years, you're doing a lot of pathophysiology, anatomy, regular physiology. Pharmacotherapy is basically when they start teaching you about the clinical application of what meds are appropriate in certain disease states. But then you also have your basic pharmacology classes, which is where you go into into great depth about how medications work.
Mm-hmm. Yeah, I remember actually like my first actual pharmacy class. The professor opened up with like basically like how do you get drugs into bodies, and it kind of like blew my mind. I never thought about this. So you swallow the pill, but that's not always the case. You can have a transdermal mode of administration. IV, sub-Q, IM. Like there's so many ways to get it in that really, I'll probably never forget that. And I don't know why that blew my mind, but it did.
There's like dosage forms where you learn about, okay, what's the difference between an elixir and a suspension, and
like why can you not interchange them?
Right.
Yeah.
And and like pill actually isn't a technical term. You really shouldn't be calling things pills. It's really like either a tablet or a capsule or a caplet. And so there's a lot of practical things. And then later on, your second and third years, you might have a compounding class or two.
There is a big focus too on pharmacy math. So like pharmacokinetics, which is basically how drugs perform or work in your body, and how you can predict, levels at certain times, depending on different drug properties, how lipophilic, hydrophilic they are. It's more of a cellular level, kind of, and more chemical level, all the way up to the clinical result of that, and when it's appropriate to do things.
Yeah, pharmacokinetics is one of those classes where you have to predict levels, and there's specialized equations on how to calculate if you get a certain dose of a medication in X number of hours based on population kinetics, like how much of that drug is going to be left in that patient's body, which you do a lot in hand in school, and then when you graduate, you realize that there's a lot of computer programs that can help you do that for you. But there are definitely skills that you do use in real life. Maybe more so in the hospital than if you were in the community, but yeah. And then similar to like Jenessa said, in my third end of the third year into the fourth year, we went on rotations, which was like 12 months. For experiences anywhere from 4 to 6 weeks, usually around 10 of them. And you get to go to, a community pharmacy and work for a month. You get to go to an inpatient hospital and round with an internal medicine team for a month. There are some specialized rotations too that are available for students in pharmacy school. One that I did was I had the opportunity to go to Scandinavia for 6 weeks. And we went to Norway, Sweden, Finland, and kind of saw how their pharmacy practices were compared to us. And we had a couple projects we had to do on rotation. And Jenessa went to Alaska with the Indian Health Service. You were there for 2 months.
2 months, yeah. And they really try to, I think any school, they have, kind of like, you need to do a community. You need to be in an institutional hospital. So basically working on the operational side in the main pharmacy piece of a hospital, and then a clinical hospital, and then an ambulatory care. So they really try to spread you out. It's a great time to figure out what you actually like, because unless you have had multiple jobs throughout pharmacy school, it's really hard to know what setting you like, because we could sit here and talk to a blue in the face, but it's really hard until you're there experiencing it to understand where you can see yourself practicing. So and that last year is really helpful.
And during rotations, you're exposed to things that you didn't even know were possibilities for a pharmacist. One of the things that I seriously considered was I had an informatics rotation where she was a pharmacist, but she worked heavily in IT at one of the major hospitals in Florida, helping formulate their computer systems, dealing with the Pyxis machines, dealing with their IV checking system that they had there. And so there's a lot of opportunities for technology, and if you're really interested into that, right? Because there's pharmacists at UVM, we have Epic, and there's pharmacists that work solely in trying to build the medication entries that the doctors will see when they type in Tylenol, like which entries come up and that sort of thing. Another thing we didn't really talk about was the opportunity for pharmacists to be in ambulatory care. So we actually, and this has kind of been over the past 5-10 years, there's been an increase in pharmacists out in the community where you might have a pharmacist who works for your primary care's office, and the PCPs there could, consult the pharmacist for questions with there, or even have set up appointments for patients to see the pharmacist. Like, hey, this patient just transferred to me. They have a whole bunch of meds on their med list. Can you go over all their stuff with them and recommend if we can stop any or whether we should start any, etc.
Mm-hmm.
And one of my rotations was in an osteoporosis clinic, and we basically, had a collaborative practice agreement with the physicians that we could just prescribe under the physician's name appropriate osteoporosis therapies for certain patients.
Mm-hmm. And I would say probably the biggest areas in AmCare that have agreements like that and that really utilize pharmacists are probably diabetes clinics, so endocrine, and what was I going to say? A lot of
warfarin.
Yes, anticoagulation. There's certain meds that really require special attention that have a lot of interactions. And so they really utilize pharmacists there. And I would say probably cardiovascular clinics, like hypertension, and managing those kinds of chronic disease states, pharmacists in the ambulatory care setting are heavily used.
Yeah, and infectious disease too, with HIV and Hep C, where the med regimens can be very expensive, very complex. Very often the pharmacist will basically be the person organizing the appropriate regimens for those patients and making sure that they get approved, and following up with compliance and things like that.
We just talked a lot.
Yeah.
No, that was great.
That was
I think that it's so interesting to hear about, especially when you get into those more upper level courses and things like that. And then there is a question in the chat, and it says, this person was wondering if you could talk about pharmacy saturation and how hard it is to find a job post pharmacy school, and if you have any recommendations for finding or getting a job in pharmacy.
Yeah, that's a great question. So I think when Jenessa and we graduated pharmacy school in 2013, and I think we were probably at the very end of where things were looked really good for pharmacists. And I think for the 5 years after that, it started to get pretty saturated, where a lot of pharmacy schools were opening up. At least
in New England too.
Oh, in the South too.
Okay.
In the South
too.
In the South too. And so a lot of pharmacy schools were opening up new satellites, and new pharmacy schools were opening. And it was definitely kind of, people were concerned that this pharmacist bubble was going to burst. And it did get more challenging to get a job. I don't think it ever was super dire. I will say that if you are interested in becoming a hospital pharmacist, or you're interested in a particular specialty, finding a position, if you're trying to stay in an urban area without having at least a PGY1 pharmacy practice residency would be challenging. It's interesting in Vermont, I think it actually is for some reason, it seems like we're always hiring people.
Somehow we're always expanding.
And I guess it's a part of that we are expanding and adding new positions to us. But I know it's not like that all across the country. So, and if you're willing to move elsewhere, your chances of finding a good job are higher. But if you're restricting yourself to a particular area, and you're interested in hospital, I think without, maybe a residency, it would be a little bit hard to market yourself.
I would say regardless of what you're thinking, just know that it is more saturated than it used to be. And my advice would be, as soon as you even think you might be interested, try to shadow people, try to, get a job in a pharmacy. They're always hiring technicians, whether, you get the intern title or not, but as a technician, not only are you building experience, and you can put that on your resume, and that's something that's definitely going to give you a leg up for sure, having any experience in any pharmacy. But it's also going to help you realize what setting you want to practice in. So I would say get into the workforce as a technician as quick as you can, and don't be afraid to try different settings, because like I said, that'll only build your resume and help you have more clarity where you want to be.
And we both, when we were first and second year of pharmacy school, we both interned at CVS. And so I worked at CVS for a year, and then I was like, I don't know if I really like this. And I basically shot out emails to all the local Florida hospitals I was near, and was able to, it's like, hey, is anybody looking for a technician position or a technician? I'm like licensed already. And I was able to get a job in the hospital, and they quickly realized that was the better choice for me.
Yep. Yeah. I worked at CVS throughout school. It was a great experience. It really taught me, not only things about pharmacy, but how to handle people in difficult situations. And like Jeff, I knew right away, probably day one, that that's not where I wanted my career to go, but I did see the value in it, in keeping that job and learning. So I stuck it through for about 4 years. But it was a great experience, and you'll never, no one can ever take that away from you whenever you experience. So get your feet in is my advice.
Thank you.
But to circle back, I mean, overall, I think the job market is, consistent with how it's been in the past couple of years. I don't think it's,
it's not
terrible.
like impossible to find a job.
You can find a job, especially now.
But it's not like it was pre us. They were like paying people bonuses to work. It's not like that anymore.
Yeah, like our preceptors when we were in school would tell us stories about going to like these large conferences where all the drug reps were giving out cars and stuff like that.
No, it's not like
that's not like that anymore.
Thank you. And you answered this a little bit with the technician advice, but is there a lot of shadowing opportunities, especially for younger students, maybe in high school, who want to see what pharmacy's like and potentially apply to one of these PharmD 6-year programs?
Yeah, as far as like shadowing in, a hospital, or I can only really speak to our hospital, but there is definitely opportunities for that. We do have one supervisor that sort of organizes that, and it would only be a couple hours, and, you get paired with a pharmacist, and, I've definitely had high school students with me, and I try to give them a good sense of, what the day is like. And I honestly think that even just shadowing for a few hours for someone who doesn't really know what pharmacists do or what the hospital is even like we forget what we didn't know. I knew nothing.
Right.
I never shadowed anybody as a high school student, but I wish I did, because I think it would have answered a lot more questions a lot earlier for me. But yes, I would say just reach out, start somewhere, email somebody, and I'm sure eventually you will get to, get pointed in the right direction. But I know that, yes, that opportunity exists for high school students and up.
I also like kind of just within the same topic of almost like pre-school things or like job opportunities. And when you were talking about how you're both technicians, I was wondering like if you could just speak about like what that type of role looks like, because I think that that's a job that's more accessible for younger students, or postgraduate before potentially going into one of a PharmD program, but kind of what their job looks like in the pharmacy.
Yeah, that's a great question. So, it depends on this. First of all, I'll say it depends on the state in terms of like, there is some licensing requirements that can happen.
They do.
But, at least at UVM, we take what we would call like a pharmacy tech trainee, and we have a whole regimented education program for them in terms of how to become licensed. So that's not an issue. But the role of the pharmacy technician, in the outpatient world, what a pharmacy technician is doing is essentially filling the actual prescriptions for, the prescriptions that get called into the pharmacy. They're handling, patients at the register, talking to insurance companies, making sure things get processed through insurance companies, and assisting the pharmacists in the outpatient world. For the inpatient, the technicians have a lot more opportunities to become more specialized. So, when we have somebody who's never really been in a pharmacy before, and actually, I think, can you go to the next slide real quick?
Yeah.
Okay, go fast to the pictures. Sorry.
Yeah, the pictures might help. The case may help us to actually like explain things.
Okay, yeah, this is a good one. So the picture on the left is what we call our pharmacy carousel. And essentially inside those bins, it's kind of like a fancy Ferris wheel, and the whole thing just kind of circles around like this. And so when, a provider puts in an order and it's not already located on the floor, it actually will pass through the system where the bins will circle and it actually flashes, and the technician actually has to grab the medication. It's all unit dose, like little tiny packets of Tylenol or Lisinopril, whatever medication it is, and they scan it to make sure it's the right thing, and then the pharmacist checks it. So the technicians will be doing a lot of sort of that kind of, filling the packages with meds, delivering medications to floors, answering the phone calls. So those are kind of the original ones. As the technicians get a little bit more experienced and they're a little bit more comfortable with their pharmacy math, then we can start training them in the IV room, which is in that picture on the right. And so you can see, like, in the back, we have the hoods, and then the far back is the clean room, where we have another set of hoods where we make all of our TPNs or IV nutrition for patients. And so the technicians are trained in using IV medications and how to compound them, which in some of the things can be pretty intense.
Yeah, I mean, definitely strong math skills are needed for this, and a good foundation, but you do learn on the job. But I can't speak highly enough of the technicians that we work with.
Mm-hmm.
I value them immensely. They are amazing. They know how to work all these pieces of technology. I do not. They man these things. They fix them when they break. They help us, if we're out of this day and age, everything's on shortage. We have to deal with, we don't have, normal saline bags in this size. Like, what can we use? What do we have? You don't have the right spike to make this, the right needle. We're working with them so closely, and, they have so much experience doing all this. They are quick to offer suggestions for alternatives. They're wonderful. I can't speak highly enough of them. But like Jeff said, kind of starting more doing unit dose prescription filling, then progressing on to compounding things like intravenous medications. We as an institution also have other opportunities for growth. So beyond this, you would come potentially work down in the oncology clinic with me, compounding hazardous medications, which is kind of a step above that if you're interested. There are other technicians that focus solely on the Pyxis machines, which are the tablet, whatever, medication vending machines on the floors. They break, they need attention, they need updates. We have technicians that is their job. They do that.
Then we have technicians that deal only with controlled substances. So I don't have a picture of that in here, but there's a whole separate room in the pharmacy that's just it's like
wall-to-wall controlled
substances. Controlled substances. And so they make sure that they're following up the legal requirements for that the paperwork is submitted. There's specific forms that need to be submitted to the DEA when we order Schedule 2, like really high, like oxycodone, hydromorphone.
They deal with
substances.
If a nurse drops a morphine on the floor and steps on it and crushes it, that has to be documented somewhere. They do all of that documentation with the nurse. They do a lot. Yeah,
they do. And actually technicians, as they gain more experience, the technicians have really been shown sometimes to be like, oh, hey, I don't think this looks weird to me.
Oh, they've
And
saved my
then
butt
you're like,
many
oh my God,
times.
that's not right. Or, and so a good technician can be really, really a valuable asset to the pharmacist.
Yeah, we work together very well.
But for the entry level, obviously, like Jenessa said, we have at UVM, we have a really great onboarding process for all these technicians, and they never advance somebody to the next step until they're comfortable doing the tasks that they can. And, you know, if you have a decent head on your shoulders and you're willing to learn, I think most people, and you have the ability to communicate well, that's actually, communication is really important to be able to talk to the pharmacist, to the nurses on the floor, when you're answering the phones. I think, you know, it's a really good opportunity for people to succeed.
Thank you so much for sharing. That's really great information. I'm just going to move us back to the Q&A for just a few more questions before the case study. You guys talked a little bit about this with COVID. I just wanted to know, since there's so much news about new COVID drugs, COVID vaccines, what recommendations do you have for reliable information and what these new drugs really mean, how they've impacted your work at the hospital?
Yeah, I mean, as far as resources go, the CDC, you know, for anyone, you know, from healthcare provider down to, you know, just regular community member, they definitely have the best information, I would say, and probably that's where I go. I actually went there today to reference some vaccine information. So that would definitely, like, that's definitely the place to go.
Yeah, I mean, and the hospital also being affiliated with UVM, we do utilize the data medical library for a lot of stuff. That's how we have access to a lot of our primary literature. And so, you know, when a patient might say, hey, like, I'm actually really interested in taking ivermectin, you can like, well, let's actually look at some of the primary literature and go over it, and we'll explain why maybe it's not on the hospital's protocol for COVID.
Yeah, and the thing with COVID too, just because everything has everyone's attention, obviously,
Sure.
And, you know, as soon as any valuable information is available and, you know, published to the public, you want to find it, right? So, and it might be in its very raw form, right? So it might be, you know, that phase 2, phase 3 study that might not be the easiest thing for, you know, my grandmother to read. So, you know, we find those studies. I don't know if they're paid for by the hospital or whatever. They may not be super accessible to the general public, but, you know, it's our job to find them, interpret them, and then field questions about them. So it might not be super easy to find the information if you're don't have the right, you know, access tools. But
yeah, I mean, and a great thing to piggyback off of this is that the hospital, also, we have a lot of drug information resources just at our fingertips, because, you know, with the amount of drugs that have been developed over the past however long, hundreds and hundreds of years, there's no way, hey, there's old drug there.
Sure.
But, you know, there's a lot to know, and there's simply no way that we can know everything off the top of our heads, right? And so, you know, the hospital does have resources like Up to Date, which uses Lexicomp for drug information. We have Micromedics, which is another drug information resource. We have textbooks that are just like lying around the pharmacy available for us to use. There's definitely a lot of information that we can access quickly, and that has, you know, good, well-sourced data from primary literature that's summarized into a convenient way for people to digest. Now, if there's a patient that's admitted that's asking about, you know, a particular medication, obviously we'll use that information and translate it into a way that that patient would understand it best. But I never feel like we don't have the resources that we need to provide accurate information and literature to folks that ask for it.
Mm-hmm.
Yeah.
Wow. Well, thank you for answering that question. And I'll ask one more before we move on to the case study portion. But I was just curious, as I know that, you know, like the opioid crisis is prevalent all over the country, but I do know that Vermont also has a pretty tough time. And I was wondering how that kind of affects your job, especially with, you know, the overprescription of pain medication.
That's a really good question. And I think I wish we had an ED pharmacist here because I think they would have a good perspective on that as well. I think the side of that we see are the patients who get themselves in trouble enough to become admitted. So we see patients who are potentially intravenous drug users come in when they have endocarditis, which is basically a bloodstream infection that causes a big old clump of bacteria and clot to be stuck on a valve in their heart. And they need to be treated for weeks and weeks with intravenous antibiotics and potentially need surgery. So really complicated, complications of intravenous drug use that require hospital admission is what we see. We as inpatient pharmacists don't really have to worry about, is this person, filling OxyContin at 5 different pharmacies. Unfortunately, the community pharmacists do have to be more of a policeman as far as that goes, and be very vigilant about, is this a fake prescription? Did they just walk across the street from Walgreens, and did that pharmacist refuse to, fill something? Is there diversion going on? We're sheltered from that as inpatient pharmacists. And honestly, I give so many kudos to my colleagues that work in the community and deal with that, because it can be exhausting and scary, honestly.
Yeah.
But no, so we see mostly the complications of that. I think the ED pharmacists definitely see other sides.
Yeah, I mean, I will say Vermont is really lucky because they have laws in place that will prevent, when patients are discharged from the hospital post a surgery or whatnot, there's laws in place that limit the amount of opiates that folks can get prescribed after the surgery. So coming from the hospital institution setting, the opiates are limited in terms of what can actually be prescribed to those patients upon discharge. Other things that we manage in terms of opioid crisis stuff at the hospital, when patients are admitted that are chronic methadone clinic patients, we make sure that they can continue their methadone therapy while admitted if it's appropriate. There's a couple other instances where we have patients that are, have substance use plans with their providers, whether it be outpatient or a hospice within the hospital, that if there's a concern about diversion, we might do simple things like change it from tablets to liquid, so that we're not concerned that the patient is cheeking their tablets and that it's, administered with the nurse under direct observation.
And actually, just made me think of something. So this is, part, whether it's, a controlled substance or not, whenever a patient's admitted to the hospital, we do our due diligence to make sure that what the physicians are ordering as their meds that they think they were on before they were admitted is correct. And Vermont does have statewide systems where we can kind of log in and see, oh yeah, they fill their morphine, at Kinney's every month, and this is the dose. So we look at that and reconcile that on admission, because unfortunately there is no master list of these patients' medications. There's a list at their primary care, there's a list at the hospital, there's a list at the pharmacy, there's a list at the other pharmacy, and none of them match. So it's our job to figure out what's actually going on. But what Jeff made me think of with that comment was, we need to be checking those things, especially for controlled substances, because it can actually go the other way. So I once had a patient that looked like they were on a lot of opioids in the outpatient world. They were filling them consistently. So the physician reordered that. Not very much long after a dose was given, the patient was completely unresponsive. Come to find out, the patient was filling these medications, but then selling them and not taking them. So you never really know, and you try really hard to, solve these mysteries and work with the physicians and, think you get the answer, but sometimes you can't.
Accurate medication lists are so important.
It will, and none of them are ever completely accurate.
Thank you so much. And so we'll move on to the case study portion. I also just wanted to mention, this conversation just reminded me, I work in primary care and we have a pharmacist that actually comes and counsels patients and is an addiction specialist. And so that's a Monday through Friday kind of 9 to 5 type pharmacist, but just another avenue you can go down.
Yeah, absolutely.
And so I'll let you take it away into the case study.
Yeah, I kind of put this together, or we did, just to give you a more practical sense of, what can happen in a day, this is actually, I would say, typical things that happen every day, but we kind of cram them all into one patient. So this patient's pretty unfortunate, but she definitely highlights, what we go through on a day-to-day basis. So MP, she's a 60-year-old female who arrives to the oncology clinic for a new start of chemotherapy. She has metastatic breast cancer. You can see here her past medical history includes constipation and chronic kidney disease. And she had a bunch of labs drawn today, but kind of the most pertinent one is that her creatinine, which is a marker of her kidney function, is elevated, meaning that her kidneys might not be working as well as they should be. That number 1.85 should be closer to 1 for reference. So when I'm working in the clinic, I'm sitting right in the nurse's station in the middle, and I'll show you pictures in a minute, kind of in the middle of all the hustle and bustle. So there's patients all around in their infusion bays getting their infusions. There's nurses, there's physicians, kind of everyone doing their job. So a physician, it's not uncommon, can come up to you and ask a question. So in this case, a physician walks up to you and lets you know as a pharmacist that he wants to start paclitaxel, which is a form of chemotherapy. But he is worried about this patient's renal function and asks you to look up, does this need to be dose adjusted because of her renal function? And he also asked if any medications could worsen her constipation because it's a big complaint for the patient and she obviously wants to avoid worsening it. So as a pharmacist, you would go and review any pertinent information. So usually for questions like this, I would start with the package insert and treatment guidelines and dig deeper if necessary. So in a case like this, you do your research and find out that this particular chemotherapy agent, paclitaxel, is actually not renally eliminated. So the way it leaves your body is actually through the liver and not the kidneys. So his concerns about her renal function don't need to be addressed because her kidneys should not, or her failing or her not perfect kidneys will still eliminate the paclitaxel out of her body efficiently. So you can inform the MD that there is no need for a dose reduction of that agent. And then as far as his question about the constipation, the big thing with chemotherapy, as pretty much anybody probably knows, is GI or gastrointestinal side effects. So nausea and vomiting being the big one. So a lot of them are a lot of chemotherapeutic agents are administered with pre-medications, which are meant to prevent nausea and vomiting from happening at all. So one of the standard anti-nausea medications given with paclitaxel, called Zofran, it actually has a very high risk of constipation. So in a case like this is something that maybe should, be avoided if possible. So the pharmacist can go and come up with an alternative that would not cause constipation or not worsen this patient's constipation. So then you talk to the physician, let him know all those things, and he says, great, and signs the orders. And after chemotherapy orders are signed, they are then reviewed by 2 independent pharmacists, which is different than any other hospital medication. So, if Jeff gets an order up in the ICU for Tylenol, he's the only pharmacist that reviews the Tylenol order and approves it. Any chemotherapy agent that gets ordered is reviewed by 2 pharmacists. It's kind of a higher up regulatory kind of nationwide requirement because they are so high risk. So the physician signs it, 2 pharmacists review and process, and an oncology trained technician will then make the medication. So as you can see here, this is the actual, I took this screenshots from work. So this is the actual product. And we didn't talk about this, but we actually have a program at work where when the physicians are working in the technicians are working in the IV room, every single step they take to make an IV product, they take a picture of, and it's saved forever. And that's how we check their work. So back in the old days, we used to have to go into the IV room. They would draw up the dose, make the dose, put everything they did on a cafeteria tray, and we would go back and check, oh, okay, they, pulled the syringe up to this level. I think that's correct because the drug's already in the bag, but they pulled it back to this. Could be wrong. Don't know. Got to trust them.
Yeah, if they would have an empty vial. It's like, yeah, I promise I put 2 mils of drug into this bag.
There were flaws in the system. Yeah. But for this system, they do it in as they're making the product. So it's much safer. You can reference it if you ever need to go back and double check something. And the perk is I don't have to actually be in the IV room. I can be checking this from home. I can be checking this from the nurse's station while the technician's, 200 feet away in the hood. So it really has revolutionized the efficiency of checking IV products. So the oncology trained technician goes ahead and prepares the paclitaxel. You see on the right is the actual vial of the drug. And for her particular dose, he drew up the wrong amount of drug. This does happen, not too often, but it happens a decent amount, and it's part of the reason why we have jobs. And when something like this happens, it's our job to figure out, is it fixable, or do we have to toss the entire thing and have them start from scratch? So as I'm checking, I notice the incorrect amount. I let the technician know and realize, you know what, you can actually, it was too little. You can put in two more. I calculate the amount of, milliliters that need to be added to the bag. He can take it back in, add it in, and then we can give it to the patient.
This is a really good example of why math is so important, right? So if this patient's dose is 130 milligrams and you were short, 12 milligrams, how many more mils do I need to add to the bag? And so with paclitaxel being 6 milligrams per mil and the concentration, you can do that math easily. But stuff like that is very common pharmacy math.
Very common pharmacy math. And this is math. It's pretty simple and should be, technicians should be able to do this. But, ultimately it's my job to ensure that I'm telling them the right amount to draw up, and triple check that and make sure it's correct. Because they work under me, and anything that is incorrect we are responsible for legally. Yeah. So you can see that was incorrect, drew up the wrong amount, he fixed it. Life is good. But I just wanted you to kind of see what we're looking at when we're checking IV products. The only other thing I'll point out too, which is kind of cool. So given the fact that chemotherapy is hazardous, it is, it's a danger and a hazard for technicians to potentially be exposed to these medications. We don't want them to be exposed to it because they're not the ones getting a therapeutic benefit from it. So we have a whole system at UVM, and now it's pretty much the standard across the country to not use needles when compounding chemotherapy. So you can see the syringe in that picture on the right. The top of it does not have a needle. It's a system that we call Texium, and it's actually a vacuum screw system. So you can see that the top of that syringe actually would screw into the top of the paclitaxel vial. It's kind of like a little twisty. And the only way you can even move the syringe is when they're completely locked in together. So it prevents any spillage, it prevents any exposure, it prevents any vapors from coming out. It's a very safe system, and really helps protect our technicians and nurses. Okay, so the dose is made and it goes to MP. So I took these pictures at a later shift, no one was there, but it gives you an idea of where I work. So the picture on the left is the nurse's station in the infusion center. So I work all the way on the chair all the way to the left, and the charge nurses work in the other two stations. And all around, that's kind of in the middle, and then all around us, there are infusion bays like the picture on the right. Each infusion bay has 4 chairs that patients sit in to get their infusions, and 1 to 2 nurses kind of manning all those infusions. So this patient sits down in one of those chairs, a nurse, 2 nurses actually, double check everything, hook her up to the chemotherapy and start it running. And unfortunately, paclitaxel is notorious for infusion reactions. There is an additive in it called cremophore that is just a very reactive compound. So that's part of the reason why a lot of pre-medications are given. But if someone reacts to paclitaxel, it's usually not a surprise. Sometimes it can be severe. And in this case, this patient did have an infusion reaction, which usually causes, a little bit of a kerfuffle, because it does compromise the patient's airway. There is a risk to the patient's life when this happens. So this happened for this patient, and as soon as this happens, usually someone's running over to me asking me to approve a rescue medication or 5. So that's what happened in this case. So eventually we stabilize the patient, we give her these medications, give her the care she needs, stop the infusion, and she's fine. Here's where it gets a little
Here the story gets a
bit of a
little not
stretch. We
believable.
kind of wanted to transition this patient into the inpatient setting. So Jeff could talk a little bit about this. Usually they don't go from having an infusion reaction to immediately spiking a fever and having a UTI, but in this case, she did.
So in this case, if her cancer is cured, she's
not cured, but she's stopped reacting.
But so anyway, so now she's admitted for observation, and let's say that she got admitted to the medical ICU because she was very critically ill and her airway was compromised. Maybe she was intubated for a brief little bit. But anyway, she got extubated, but she's not doing very well. And so, she's complaining about urinary symptoms, and the doctors are concerned, like, oh, you know what, maybe she has a urinary tract infection, but she's very sick. So we want to make sure we give her some IV antibiotics. And so the doctor orders ceftriaxone, which is an IV antibiotic for a possible urinary tract infection.
So a different pharmacist.
A different pharmacist. Yes. So now
the patient is not here. They are up in the ICU.
And so now they're like in my land, where I can then see that order for ceftriaxone. I'm like, oh yeah, this patient just got transferred, and I think now she has a urinary tract infection. We can approve it, and then we'll dispense the ceftriaxone to the floor for the nurse to administer.
And just as kind of a comment, so this is a typical antibiotic to start in somebody you think has a UTI, where maybe you take their urine, you send it to the lab, it takes time for any bacteria to grow. So this is something that will cover most of the common things that would cause a UTI until you know exactly what it is. So we start that.
All right. And then let's say, the next day, we talked about going on rounds. And so in this case, the pharmacist, RPH stands for registered pharmacist too. I don't know if everybody knows that. Notice that the urine culture has resulted from the lab, and it looks like it was greater than 100,000 CFU per mil of Enterococcus faecalis, which is actually a organism that ceftriaxone misses in its coverage. So now we have this drug bug mismatch where this patient's receiving an antibiotic for which it doesn't cover the organism that grew out of the urine. So effectively, we're not treating a urinary tract infection, and we're putting the patient at risk of having worsening symptoms, or maybe that urinary tract infection, progressing to a kidney infection. And so this is a classic intervention that I personally have made on rounds, and I think Jenessa, you probably have too, where we can say, hey, the urine culture came back, guys. It looks like it was this bug. Why don't we switch this, IV medication to ampicillin, which is another IV antibiotic that would cover that. And then, usually the team is very grateful that you came up with this recommendation, and they went to switch it. And in that recommendation, this patient also had bad renal function. And so we were able to say, hey, instead of doing the standard dose of like a gram every 4 hours, we should back it off to like 1 gram every 8 hours.
And we're not making this stuff up like you're making it sound like we're looking at what the recommendations are and telling
let's say this is something that in the morning I would have reviewed and like, oh wow, yeah, this is gonna be a good intervention for the pharmacist today. You get really excited when you find something. I can't wait to tell the team, and then you tell them and they accept it, and everybody's happy. And I will say, and the culture is different in varying hospitals, depending on where you are, but at UVM, the medical staff is very receptive to pharmacy involvement. So if the pharmacist has a suggestion for a drug change or a dose change, you say, hey, I think we should change this from X to Y. They'll say, yeah, go ahead and do it.
Yeah, sometimes it's a little scary. I'm like, wait, don't you want to talk about this? But it's a great environment to work in, and it does show just like how open everybody is to having, to listening to other specialties, and, what a good rapport pharmacists have, at UVM. But you definitely need to know what you're talking about and have literature to back it up, because a lot of times they will just take your recommendation and do it, and you want to make sure you're recommending the correct thing.
And then there's other scenarios where the answer isn't crystal clear, and the pharmacist can be a great resource to say, you know, we have these two options, these are the pros of this one and these are the cons of this one, and vice versa, and present that to the medical team on rounds. And then, you know, ultimately the decision goes to the provider, but to have that information ready and it's sort of succinct enough for them to be presented with, you know, the interns, the residents, the attendings, etc.
So we saved our patient.
Yay!
So we already saw these pictures. We don't need to talk about them again.
Oh yeah. Okay. So this is
Well, so
go ahead.
what do you want to talk about?
I want to talk about this one.
Well, we'll do them last.
Okay.
The picture on the left is just an example of kind of the old school way I was talking about for IV product making. So the cafeteria trays with the syringes, you can see the stickers on the syringes to where the technician actually drew up the med and then put it in. There's no longer drugs in those syringes. They're currently in the bag on the left. But I have to trust that that's actually what they drew up and then told me what they drew up. So it's definitely cleaner and a little more, there's more confidence when you're checking through dosage or through that, the picture program that we saw. But we do make products like this because the IV program isn't smart enough to do more complex things. So we still do this for probably, I don't know, like 10% of our work.
And then the middle section is just where we keep all of our oral liquids. And so basically for any patient that can't swallow a capsule or a tablet and needs to get a oral liquid medication, like the technicians on the bottom, you can see there's all these like orangey brown syringes. So the technicians will go and they have labels for the syringes and the bags, and they'll take each dose and they'll draw it up to the appropriate thing. And then the pharmacist will check that appropriately and make sure that it was the right drug at the right concentration, the right volume in the syringe. And a lot of like neonates and kids get oral liquids, as you can imagine. It's hard to tell a 2-year-old to swallow a capsule. And so we do that. And then the last picture is actually, you know, with all the modern medicine we have, sometimes we kind of use old school remedies. And so we do have a leech hotel.
Yeah, we call it a hotel.
That's what it's called. That's really the term.
It's basically a bucket of leeches that we have to make sure we put the right salt solution in.
Yeah, there's a very specific amount of salt that has to be in the water for the leeches. And the leeches are primarily used in plastic surgery cases where there was like a severed finger and the surgeon reattaches the finger, and then they'll use the leech to help draw the blood back to that appendage that was cut off to restore blood flow to that area. And so we dispense them in little cups. And
it's weird. But this is such a small part of our job. But we thought if anybody was falling asleep, this would help you wake up, because they are weird and creepy.
And one time the technician was changing all the leeches and they dropped it.
And there were leeches all over the floor. Yeah.
And
they're expensive.
They're like $50 a leech.
And what's the website?
Leeches USA.
LeechesUSA.com.
But they're very fast too. They're very fast. And unfortunately, all of those leeches had to be disposed of. But that's okay. Such is life.
So yeah, wide variety of stuff that we check.
Wow. Thank you so much. That was such an interesting case. And I really like that it really shows the whole process of, you know, what you would see or expect, especially like at an inpatient setting. And just kind of based off of that, I was wondering like what the typical timeline it was for like when the two of you would get an order from a doctor based on what a patient is presenting with, for you to then review that, I guess like fill the order and then have it leave the pharmacy for the individual to take that medication.
So that's a really, really good question. And it definitely, we prioritize our workload based on the acuity of what is needed. So probably the fastest example or the most extreme example as far as quickness that we as a department have a process to get this out quickly is for stroke patients in the ED or wherever, stroke patients, thrombotic stroke patients that require the clot buster alteplase. So if we have like a whole stroke team of physicians, and once someone's suspected of having a stroke or is coming in the ambulance that we think might need this medication, we get a page. And as soon as they image the patient and decide to give it, they call the pharmacy and we compound it as quick as possible and literally have a technician run to the ED to give it to the nurse to give. That turnaround time from when the order's put in to when it's going into the patient, we've actually studied this, it's less than 10 minutes. I think it's closer to like 6 or 7. Yeah.
But for the other orders, like a standard order for, I don't know, an anti-nausea med that's already loaded in the machine on the floor that we call Pyxis. When the doctor puts in the order, it pops up on we have a screen that's basically kind of a queue of meds that we can go into it and look at it, look at the patient's chart and see why they're here, is it appropriate? Then once we verify it, it's available for that nurse to access out of that machine, probably within 5 minutes, like less than that.
Like 2 minutes. However, so there's multiple components to this. So the verification process where the physician clicks sign, then I see it, I open it. So that process right there of me, evaluating whatever I'm evaluating with the patient, that could take me 30 seconds, depending on what it is, or it could take me 15 minutes plus. It depends on the complexity of the situation. Like some things even longer. So it just depends. Even if something's very acute and they need it quickly, I want to make sure it's correct and safe before I click that button. So that timeline can vary. And then once I click the button, it could be as simple as the nurse just needs to open the Pyxis machine, or it could be an extremely complicated compounded product that we need to write up on that card on the tray. This technician needs to take forever to, like, it just depends.
They have to compound it.
Sometimes they have to compound it. Sometimes if they have to reconstitute it, it's out of their control. And like when they put the liquid into the vial of powder, it could, just by nature of the chemical makeup of the drug, take 15 to 20 minutes just to go into solution. Or it can take 3 seconds. So there's a lot of pieces to it. So it could vary from 30 seconds to an hour plus.
Or hours.
Hours plus. Yeah.
So the answer is it depends.
Yeah.
But does that prevent nurses from calling, asking if it's ready? It does not. But we try to, we give the real answer in terms of, hey, this drug takes a long time to reconstitute, so don't expect it for another hour. Mm-hmm. Or it can be like, oh yeah, I was just grabbing lunch. I'm sorry. I'm going to verify these orders right now, and it's, when you do it and it's ready for them. So it varies.
Good question.
Yeah.
Mm-hmm. Thank you. This might be a silly question, but I was wondering if you have any advice for pronouncing drug names. It's something I find very difficult and wanted to know if there's any pharmacy tricks for it.
Oh God, there's no trick.
No.
I mean, good luck with the new COVID monoclonal antibodies. Oh, I'm like Bamlanivimab. Yeah. I don't know. It's too much. So yeah, a lot of it, there's no trick.
Is there any like phonetic thing online?
No.
Yeah, no. I mean, the closest phonetic you can get is like looking at the package insert. I think they have pronunciation like in parentheses.
Not all of them.
But not all of them. And when in doubt, just like spell it out.
Sounds good.
No, or ask a pharmacist friend.
Yeah,
Because even pharmacists disagree on certain drugs and how they should be pronounced.
But no, there's no good reference or good tip. I'm sorry.
And then for a final question, which we like to ask all of our participants is, what is your favorite part of, working at UVM Medical Center or being a part of that community in general?
I knew you were going to ask that question. I'm glad you did. My favorite part of working at UVM Medical Center?
You get to work with me.
I get to work with my husband.
No.
It's a great environment to work in. Like, I love my job. I love the fact that, we live in Vermont, which is this, kind of picturesque state. But UVM Medical Center is, over a 500 bed hospital. It's a level 1 trauma center. We get all the really cool cases from upstate New York, all of Vermont, New Hampshire. You never know what you're going to get. I'm expected to pivot and adapt daily to different situations. And I love that. I love not knowing, what's going to come across my plate. I would not function well personally as, that Monday through Friday, same kind of patient population daily person. I know that's just not for me. So I happen to find a job that lets me rotate through different areas, cover everything and anything at any point during the day. And I love that. We're also really fortunate to have a great kind of culture at the hospital. So, I've never interacted with a nurse or a physician or another pharmacist that's rude, really. Everyone's very open to, good communication and listening to, what your opinion is. And it's a really collaborative environment, and I really like it.
Yeah, I would agree. I think, they really stress like a work-life balance.
That too, yeah.
And I think that's really important for, a lot of people, particularly in the medical profession. I think pharmacy is one of those careers that, for the most part, allows you to leave your work at the hospital or the pharmacy if you're working outpatient. That I think you take some stuff home, but ultimately there is a good ability to separate it. We're not on call ever, like a lot of physicians are, which is really nice. And so once we're home, we're home.
Mm-hmm.
I will also add that I think, this is probably similar with a lot of other professions, is that, new drugs are approved all the time. And so this is absolutely like a lifelong learning profession in terms of trying to keep up to date with things. It's kind of like they always add more and more drugs. They take a couple away, but then it just gets larger and larger and larger. And so it just becomes, you rely on so many more people who are specialists in particular areas, and there's always something for you to learn and follow up on. And every time I answer the phone from a physician or a nurse that's calling me, I never know what they're going to ask. And it could be as simple as, hey, is this drug compatible with normal saline or dextrose, which is a very easy thing for me to look up, or hey, I have this patient with this really rare thing and there's this really obscure drug that we're trying to obtain, and would it be appropriate? And are there any interactions? And really delving down into a specific situation. So it can really vary, and it keeps you on your toes and kind of makes it fun.
Well, thank you both so much for being here tonight and just letting us into your world of pharmacy. We appreciate it so much. The session will be on YouTube after, and next month on January 20th, we're going to have Dr. Lara Stone, a podiatrist, as well as some other speakers. And so definitely join us then.
Yes, thank you again everyone for participating, and thank you Jeff and Jenessa for an incredibly interesting panel, and it was really great to hear from both of you.
Thank you so
guys.
much.
Hope to see you all next month.